Thank you. Thank you, Madeline. It's with great pleasure and honor that I introduce a very dear friend, Dr. Victor Montori, who is a professor of medicine at Mayo, an endocrinologist, and a health service researcher known for his work on patient-centered care. So concepts like shared decision-making, minimally disruptive medicine, and care that fits. These are all essential concepts for guideline development, and he is the author of the book, Why We Revolt, which I have right here, which is very relevant to guideline development because we really do not consider a lot of things that are very important to patients when we develop guidelines. Victor is the founder of the Patient Revolution, which is a non-for-profit organization that advocates for a careful and kind approach to healthcare. Victor has hundreds and hundreds of scientific articles and research contributions that are widely cited in many advisory roles in healthcare policy and research and many awards. I can spend the whole hour talking about it, but I want to give you a chance to listen to Victor, who's a very charismatic speaker. In fact, Victor has delivered a medical grand round here without slides. So you are in it for a very interesting and exciting talk. Thank you very much.
Thank you, Hassan. That was a very nice presentation, except a bit about presenting without slides, which was a massive mistake. But anyway, can you see my slide?
Looks great.
Yes.
Okay, excellent. So this one has my email address. So if for some reason there's a issue that we don't get a chance to discuss or yet you would like to follow up, by all means, feel free to write. I see among the presenters many good old and new friends as well. So welcome all of you to this conversation. I look forward to your questions and comments. I'm going to start by doing a quick review of what I call the grades heuristic. So the grade sort of rules of thumb, the rules of the game that you play when you use grade to work with guidelines. And I'll simplify, but I think it serves us as a starting point. As you know, grade is a manifestation of evidence-based medicine. Madeline mentioned that this is a evidence day sort of celebratory webinar, so I'm connecting with that. And as you know, there are these three core principles of evidence-based medicine. One is that decisions ought to draw from the body of evidence, not just the latest study or the one that got highlighted in or brought to your attention by ChatGPT. It should be aware of a hierarchy of evidence, recognizing that not all evidence is created equally, that some forms of evidence are more trustworthy than others on the basis of their methodology, and that evidence alone is insufficient to contribute to making a decision, that there are other factors that clinicians have to and patients have to consider when making clinical decisions. I understand that these three will not be controversial in this group, but these are the three core principles of evidence-based medicine, and grade is an extension, it's a practical extension of these principles. Their grade relies on a couple of tools. First, to capture the body of evidence and understand its credibility, so mostly to address the first two principles, it draws from systematic reviews of the evidence. And the systematic reviews of the evidence provide an answer to questions about efficacy and safety and other important critical outcomes that indicate whether the intervention is potentially useful and usable. And so systematic reviews provide an answer, a summary answer, a synthetic answer, but also a sense of the quality of that answer, how trustworthy that answer is. Guidelines that are built on that evidence are arguments. They propose something, they suggest or recommend something. And those arguments are made with a certain quality that makes, again, those recommendations trustworthy. And the arguments are about the extent to which a particular intervention using that particular intervention, a particular patient group is warranted. It's a statement about the helpfulness of doing so and advancing outcomes that matter. Neither the quality of the answer or the quality of the argument are of direct relevance to what happens at the point of care. Because what happens at the point of care, the quality that matters at the point of care, is the quality of the action that patients and clinicians choose to decide or decide to proceed with. And really, it starts off not by what the evidence says. It doesn't start from what the guidelines say. It starts with the problematic situation of the patient. And the question for clinicians and patients is, how are we going to make the situation better? And one of the sources of information about how to make the situation better, whether we could make it better, are actually in the evidence that provides an answer to the question and the quality of that answer, and the guidelines that offer arguments as to whether this or that intervention will be preferable in this particular situation. Now, the key heuristic for this conversation from GRADE is that when the answer is not as trustworthy as we would like, or the arguments prove ambivalent as to how to proceed, then action must still follow. We still have to do something to advance the problematic situation. And the implication of a conditional recommendation based on GRADE is that we will use some form of shared decision-making as a method of care. There's substantial debate at the moment whether evidence of low validity, of low trustworthiness, and recommendations that are weak or conditional should actually be used to forego certain forms of therapy. And of course, that is a tragedy. The obligation of clinicians is to work with patients to respond to that problematic situation, regardless of the state of the evidence or the quality of the arguments. And again, oftentimes that calls for a partnership, a collaborative endeavor between patients and clinicians in deciding what to do. This is particularly relevant in a healthcare environment in which we get to make a difference in the lives of patients in two main ways. One is by fixing people. And when we fix people, it's important that we get, the right treatment at the right time to the right patient the first time with the right expertise and equipment. This first-time quality becomes really important so that we do more good than harm. We cure people completely. Now, notice that the diagonal line doesn't separate the squares at the edge, at the corner. It leaves a little bit of room. And that is because even when, for instance, when you're fixing problems, there might be a situation where the fixing itself causes new complications. Procedures don't necessarily go well all the time. And sometimes they leave sequela, either of the disease before it got fixed or the fixing itself. And those things are very similar. Survivorship for cancer comes to mind. Those things are very similar to what happens in chronic conditions, in which the effort is to manage symptoms, mitigate adverse effects, cope with disappointing results, prevent complications, rehabilitate sequela, provide self-management support, solve problems, manage care that fits. I'm a diabetes doctor, so this is mostly my activities, support, the processes that patients and caregivers go of coping with challenges, adapting to them, and eventually thriving and hopefully flourishing. Once again, on the bottom corner, you see that the line doesn't go all the way to the corner, because occasionally we get to fix some things for these patients, but most of the time we're just working with them to try to advance their situation. So this is particularly important because in most of these situations, there's really no right answer. You just have to work with what you have to figure out what to do. Of course, that line, that diagonal line, is actually highly permeable, and oftentimes we have to move in both directions. In the situation where fixing is what we want to do, variance is defect. If we're doing things in a sloppy way, we're not going to get the fixing in a reliable and consistent way that we would like to do. But in the case of responding to the problematic human situations in chronic disease, variance, in fact, could be virtue, because you are responding to the individual ways in which situation, patient biology, patient biography, and the biopsycho effects of treatments vary as people move in time and as people move over time. And so a rigid approach here is likely to be right only a few times and cause harm in other times. This is Maria Luisa, who joins me in these presentations routinely, and oftentimes I highlight that she is here depicted by a picture taken by her granddaughter, where it shows a number of medications in front of her, but a presentation of her that doesn't suggest particularly high levels of health. And the question is, how does someone like Maria Luisa get to end up with so many medications? And it really is related to diagnostic labeling. Maria Luisa accumulates a number of chronic conditions, which is a common situation as one ages, and guidelines connect each of those diagnoses with recommended approaches of treatment, including pharmacological interventions. So if you have multiple diagnoses, there'll be multiple guidelines that are pertinent, each of those guidelines recommending a particular treatment. If we only respond to diagnostic labels, if we only respond to what Maria Luisa has in common with other people with the same diagnostic labels, we're basically not practicing medicine in which we care for people like Maria Luisa. But of course, that is not our job. Our job is to care for Maria Luisa. And for that, we have to not only look at what she has in common with other people with the same biology, but we have to understand what is particular about her situation, what is particular about her life, what is particular about her goals and the things that she values at this point in her life. And we don't get to just respond to the issues of biology, but we respond to the whole person, to Maria Luisa. The process of doing that requires that we go beyond the biological expertise and the biomedical expertise that we may have to include the expertise that Maria Luisa has about her own life and where she wants to go next. This is the process of care, right? It's a practice, a series of things that we do, and a disposition to notice and respond to the problematic situation of the patient. Noticing requires a clinician to pay attention to understand the situation of the patient in high definition, not just in terms of needs that need to be supplemented, but also strengths that can be mobilized to advance that situation. But noticing, empathy, not enough. You have to turn that into action. And so it is the idea that we're not only responding, but not only noticing, but responding to these issues that actually provides hope to the patient, because that means that the clinician and the patient are now going to start work to create action, to invent action, to uncover or discover action that would actually improve that situation. And that commitment to create action creates also the possibility that the situation can improve and that the future could be better. And that is a source of hope. Caring is also caregiving and care receiving. So caring is not done when one delivers the care, as if the care was a box that's on the shelf and we just have to select the right box and deliver it to the patient. But caregiving is in fact working with each patient, mobilizing professional competence, but also compassion so that we can attend to the emotional components of the situation. And it's not finished until we know from care receiving that the response that we've co-created ideally has been deemed pertinent, adequate, and desirable by the recipient of that care, by the patient. Now, to care well, we need to have appropriate conditions for care. I think it's well known that in industrialized healthcare, which is the corporate datafied environment in which we work, many clinicians are burned out. Consultations are accelerated, people are being processed through, and rather than care. In these environments where clinicians are not feeling valued, they don't get to work in teams, they work to work in chaotic situations, their burnout rates can be quite high. And this limits the ability of people to pay attention, to notice, and to respond. So we need to have adequate conditions for care. And one hallmark that we have those conditions is the ability to have unhurried conversations. And I don't mean long conversations, and I don't mean wasteful conversations, just unhurried ones. Because it is the conversation, that's the sandbox in which we actually get to form those plans of care, is where we get to notice the patient's situation in high definition, and we get to work with patients, co-creating a sensible resolution to that situation, a resolution that makes intellectual sense. It reflects well the way we understand that situation and perhaps mobilize some of the evidence that is pertinent to that situation. It makes emotional sense and also makes practical sense. We know how to move forward in a way that is sensible and feasible into the life of the patient. So what happens in that unhurried conversation is the deployment of a number of different approaches, including one called shared decision making, which is a method of care. It's a conversation in which patients and clinicians work out what to do. They co-create plans of care that make intellectual, practical, and emotional sense. So it is not about delivering a patient decision aid, educational pamphlet, having the patient think on their own head about their own value, clarify their own values and preferences or any of that stuff. It's really a conversation between caregiver and care receiver where you figure out how are you going to move the situation of the patient forward. This is an old video, but demonstrates and it provides an example of a shared decision-making encounter using one of the one of the early uh, 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 decision support tools that we developed in our research program nearly 20 years ago in patients for using patients with diabetes. Let's see if this works.
So yes, I agree. We need to make sure your sugars are better controlled. So that means we need a new medication. So which aspect of your next diabetes medication do you want to discuss first?
Weight change.
Weight change? I'll let you review that.
Okay. So this is the one that I'm on.
Yeah, you're already on metformin.
Well, this one looks good to me.
Yeah, that one is going to help you lose some weight.
Yeah.
What aspect of that medication would you like to learn about next?
I'd say the daily routine.
Sure.
Okay, so.
Yeah.
Oh, so this is an injectable.
Yeah, it's actually very easy. There are a couple of pens that have needles, and you inject the needle into your belly and do that twice a day before your meals.
Yeah, I don't think I really want.
You don't want to go needles?
No,
Okay.
no. I'd much rather just pills.
Hmm.
So this is okay. Well then, so the sulfonylurea is.
That's the next
So
best
this
one
one-
for you in terms of the weight, huh?
Yeah, yeah.
Well, that's a daily pill, so that you can start with just one pill a day.
Yep, and just 30 minutes beforehand.
Yeah, usually 30 minutes before breakfast. Would that be okay?
Yeah, yeah.
Okay, well, the other thing to consider is that sometimes they can give you low blood sugar, so we're going to ask you to monitor a little more often than you're doing right now, but otherwise that will be okay. If you were to change your mind after you go home, I'll give you this pamphlet. It has the same thing as the cards, so as you're using the tablet, if you find that it's not what you were expecting, review this again and give me a call and we can discuss it again.
Okay.
All right, thank you.
So this is an example that is now extremely old, as you can tell by the extremely young physician in the video. But you can see that there was a number of missed opportunities, right? So when the patient says, "Oh, not injections," this is an opportunity to figure out why. Is it the patient's occupation? Is it the patient's environment that perhaps doesn't allow for this? The lack of curiosity of this clinician in this demonstration, I think, is quite palpable. The point of these tools is not to make a choice, but is to basically clarify, to notice well what is the situation and make sure that whatever plan is put forward is one that makes sense in that situation. So it's an early example, but it gives you a sense of what might happen. In GRADE, this whole thing is synthesized in that third principle of evidence-based medicine that says evidence alone never tells you what to do. One has to incorporate the values and preferences of the informed patient. So what is this values and preferences about? Well, if you think about what is at stake here that is not the evidence from empirical research, it is this idea of perspectives, of beliefs, expectations, of priorities, of goals for health and life, situational factors like the conditions of work and play and living, predispositions, aversions, cultural norms, and other stories that determine what we value and not in our lives, and the wishes, of course, of the significant others that represent our social environment. Those can manifest into issues, and issues that make a course of action more or less desirable for the participants, ideally for the patient, and are matters for the deliberation. So this is where this becomes issues of convenience, restrictions that can't have that food, can't do that activity, of risks, of adverse effects, uncertainty related to the benefits, the burdens on oneself and on others, and a general sense of distrust in medicine are all issues that will actually come to participate in deliberations about how to proceed. When considered in that discussion, you end up creating an argument in practice about whether one has reasons, strong or weak, to proceed or not with a particular course of action. And so this is sort of what is meant by these values and preferences that is a part of that great heuristic. We have found ways of sort of surfacing some of these aspects by developing shared decision-making tools. And this is one of the first ones we developed a long time ago. And this was a fairly simple one, is for deciding whether to take statins. It displays the patient's estimated cardiovascular risk in the panel on the left, estimates that risk reduction thanks to the regular statin use over a decade on the panel on the right. It has also tabs for discussing issues, particularly related to potential adverse effects and burden of treatment, and to document the decision. The core of the decision-making process as we developed this turned out not to be a trade-off, which is often something you discuss in grade, but actually an assessment of the extent to which this benefit matters to people. And whether it matters in relation to taking a pill every day for 10 years or whether it just matters, period, it's unclear to me. Notice that the risk communication strategy being used here is a risk communication strategy that reflects some of the best evidence in risk communication. If you squint a little bit, you see a bar graph where it allows you to sort of compare the heights, if I may, qualitatively. Obviously, if you read the captions, it will communicate that information with words and numbers. And if not, you're looking at a pictograph of 100 people like you. And I like to point to patients, and you're in a room with 100 people just like you, and we're going to close the door and open it 10 years later, and then we'll count. You will see that if we do that with 100 people just like you, after 10 years, 79 people would not have had a heart problem and 21 would. And I have no idea if you're one of the green ones or one of the orange ones. Now, if we give you enough statins for 100 people to take a pill every day for the next 10 years, close the door, come back 10 years later, you will see that the 79 people who are not destined to have a heart problem, they'll take the statins, their cholesterol numbers will go down, but they'll have no benefit. And of the 21 who were destined to have a heart attack, 16 will still get the heart problem despite taking the medicine regularly, despite their cholesterol numbers going down, and only 5 people will see a benefit from taking this. So out of 100 people that take the medicine, 95 will have the same exact outcome, and 5 will change their outcome because they took the medicine. And then the question, of course, is this something you want to do? And again, it's much less important to get a yes or a no, but more important to understand how our patients seeing the issue of prevention and how they see the issue of prevention in relation to taking medications for it. This has evolved over time, incorporated into the electronic workflow. This is the latest iteration of this tool, which is called the CV Prevention Choice, collects a lot more or considers a lot more information about risk, but uses the same metaphor for showing risk reduction, but now includes not just statins, but also diet, exercise, and a series of other interventions that have been shown to reduce cardiovascular risk, using the metaphor of the cards that you saw in the first video to actually identify whether the approach to reduce cardiovascular risk that you would like to pursue is one based on lipid lowering, for instance, choosing to take statins, ezetimibe, or PCSK9 inhibitors. Is it going to be more about blood pressure reduction? Is it going to be more platelet inhibition? Or is it going to be based on glycemic control or glucose lowering with GLP-1 or SGLT2 inhibitors? And you can see there on future risk that a program of work, that in this case is to start a diet, start a medium statin dose and an aspirin, is able to cut the risk for this patient in more than half. Now, it's interesting that in many of these, for many of these interventions, GREAT will be giving a strong recommendation for instance, all patients with diabetes to take statin. That the statin choice decision aid was developed when that was the recommendation. There was a strong recommendation that all patients with diabetes should take a statin. And so this is a direct violation, if I may, of that heuristic in which it is when you give conditional recommendations or weak recommendations that shared decision-making becomes the way you implement that recommendation. So why did we go in a different direction here? Because in cases of strong recommendations where the implementation of the intervention is in the hands of the patient, that the efficacy and safety of the recommendation, it's in the appropriate use of the intervention over a period of time, the patient has to plays a major role in doing so. And so their participation in informing that plan of care becomes essential for that plan of care to shot at being something you would do. As you know, most of these things that are recommended strongly and given to patients for them to implement, their adherence over the long run is pretty low, oftentimes less than 50%. And so this was an effort to actually use shared decision making to improve adherence. Another early misguided approach to this work, because it turns shared decision making as an implementation strategy for the guidelines. But I hope that you start getting the sense that I profoundly dislike this model's approach, because I don't think that the role of clinicians and patients is to translate evidence into practice, but rather it is to advance the problematic situation of the patient and use evidence to actually achieve that goal. Slightly important, it's a slight difference semantically, but it makes all the difference in the world. The job of clinicians is not to implement guidelines. The job of clinicians is to advance the situation of the patient. And the job of guidelines is to support clinicians in that effort. So what is this shared decision-making as a method itself? Very simply, it's patients and clinicians working together, addressing the problematic situation of the patient, and making progress, advancing the situation of the patient. And again, the conditions necessary for this are helpful. This is an extreme example of favorable conditions: a silent room without any distractions, a semicircular table, the computer with information or illustrations that might help the discussion in the middle of that room, and the chairs sitting next to each other, indicating clearly that this is a place of collaboration. But at the very least, an unhurried conversation with some silence will be nice. And then the readiness to engage in the appropriate kind of shared decision making. So we've mostly shown you examples of the shared decision making tools that discuss the effects of different alternatives to doing or not doing, or different alternatives to proceed, in which the work of collaborative decision making with the patient is to weigh the pros and cons and to consider these effects in the light of the patient's values and preferences. Typical shared decision making, but only one of four kinds. Another kind is when patients and clinicians hold different positions. A typical situation will be a young woman from Brazil that moves to California and becomes pregnant. And she's now considering whether she will have a vaginal delivery of her baby or a C-section. Back in Brazil, all her friends have done C-sections, but in California, her OBGYN is talking to her about vaginal delivery being natural and so forth. And so this is creating a significant conflict internally for her, because she can see both arguments, but also with her friends and her mom in Brazil, who wants to be present but needs to be planning for the date, and so wants to know when the C-section will be scheduled, and she's wondering maybe she should proceed with vaginal delivery. And so here you can present the pros and cons of C-section and vaginal delivery, but really that's not what it's play. What it's play is two positions that are at odds and that need to be negotiated with visibility, if not voice, from people that perhaps extend beyond the patient. A third mode of shared decision making is probably one that I encounter most commonly as a diabetes clinician, is the one where you have a problematic situation, and now you're going to work through that trouble situation to find a way out, to find a way forward. Think about the patient that's hospitalized, and you have the nurse, the social worker, and the family figuring out the discharge planning. When is the patient going to go home? Yes, you can have a decision made about Wednesday versus Thursday, and the pros and cons of Wednesday or Thursday and so forth. But really, here it's an issue of, okay, when is it going to be ready? Who's at home? When is the transportation going to be? Is the patient going to be well enough to travel? Would they be well enough to be at home? Can the family advance? Take care of the patient when they get home? How about are we going to be able to mobilize the remote monitoring to support that process and so forth? So it's a readiness to and a preparation of and an implementation of. And then a lot of this is a big trial and error. Let's aim for Wednesday, but now Wednesday arrives and we realize that something is not in place. We move to Thursday. You can show up with your decision made, but it's really about solving problems and making things happen. And so it's a different kind of working together to advance the situation that is not really choice-based. And then the third kind happens usually when people are experiencing significant transitions in their life. End of life is a good example, where the situation is difficult to understand, it's confusing, and it's disorienting. And the work of conversation together really is trying to develop insight, bring things together, find coherence. I like to say that it gives people the opportunity to write the last page of the book of their life with their own handwriting. Different kinds of working together to advance the patient situation, different kinds of shared decision making, and three of them do not involve choice. Here's a different kind of tool, one that that helps identify the kinds of problems that we need to work on designing, in this case, for patients with diabetes. And they're different cards. The patients can choose 1 to 3 of these cards. I struggle with monitoring my blood sugar. I find it hard to follow your suggestions about diet and exercise. Or this one, which is not a problem, but a positive card. I have felt moments of pride while managing my diabetes. And by bringing this card forward, it gives patients and clinicians the opportunity to identify what problems do we need to work through in this situation. And by the way, all the tools that I'm showing you have been tested in randomized clinical trials and demonstrated to work. And the kinds of outcomes that we capture are summarized very briefly here. We find that when patients and clinicians use these tools to promote those conversations, there's a great degree of satisfaction. Now, what's striking is the effect on clinician satisfaction. In an age of clinician burnout and the introduction of tools at the point of care that irritate us and burn us out, the fact that we're bringing in tools to help patients and clinicians have conversations actually enhances the clinician satisfaction with the visit. Many writings on shared decision making will use selective citation to indicate that shared decision making promotes all sorts of outcomes, from improved adherence to therapy to improving outcomes of patients to reducing global warming and bringing finally peace in the Middle East. And I can tell you that if you look at the summaries of evidence, you will see that the results are quite equivocal, such that I would say it's unpredictable whether the promotion of shared decision-making contribute to those outcomes. And we can discuss in the Q&A if we even know that these tools promote shared decision making. And the same is said about cost, that if patients were to participate in shared decision making, the intensiveness, invasiveness, and cost of the interventions will be much more conservative, and that really depends on the baseline. If an intervention, particularly an invasive, expensive intervention, is overused, the introduction of a conversation would actually naturally reduce that use. And if an intervention is underused, the exact opposite will be found. And in terms of the effect of time, this is a mystery that I think when you start, unless you watch video recordings as we do from our clinical trials, you don't get to understand why is it that shared decision making doesn't add time to the consultation. And all of our studies actually show that it does not add time. Yeah, the question is, what's happening in the control arm that is taking the time of the shared decision making that is introduced and occurring in the intervention arm? And it's a hodgepodge of things. I mean, my favorite is when we did a study of osteoporosis, the clinicians in the control arm would not all of them, but with some frequency, will take out a piece of paper and we'll start by drawing a normal curve and tell the patient, look, this is a normal curve. The patient is completely, enthralled by this normal curve that looks like the elephant swallowed by the snake in the Little Prince book, right? And then draws a line in the middle. Say that's the mean. Where is this going? And then says, now here's one standard deviation below the mean, two standard deviations. And this is osteoporosis over. You're like, what the hell? Right. And so the patient completely like, what is this? And so this is why you need to take medication, because you're here on this side of the curve, statistics 101 in the clinical encounter. So in the intervention arm, the patient is seeing a graph about the risk of fracture and how that risk will be reduced with treatment. And that will take about the same time, but that actually tends to be useful for the patients in considering whether that sort of prevention is helpful to them. So what are the key points that I would like you to take home? The goal of shared decision making is really not to get people to follow the care that's recommended for patients like this, which is what guidelines produce, but rather to form care plans that make sense to this patient. Shared decision making is a method of care, not a method of choice, but a method of care, and that is based on conversations, not on tools. And these conversations amplify the ability of clinicians and patients to change problematic situations. It's not to translate evidence into practice, it's not to implement the guidelines, it's to improve the problematic situation of patients. Shared decision making is not one more thing for busy clinicians to do, but it's part of how they make things better for their patients. And actually, that makes clinicians feel prouder and happier and more satisfied with their practice. And again, it's important that we not only have the tools, but we enable conditions favorable to care. One of those conditions is time. And I want to alert you to this work that we did with Gordon Guide and Mina Johansson, where we talked about estimating the time needed to treat of guideline recommendations. Guideline groups will recommend everything in the world for clinicians to do, and there's just not enough time for clinicians to do all this work. It's frequently estimated that you need 27 hours in a day to actually do everything that is expected. And here we are recommending more and more things that we think clinicians should do. So what is the time needed to treat when we want to recommend shared decision making? And this is a paper that just published yesterday that shows that the average patient will receive 1.7 hours of their primary care clinician's attention. So that's it. That's the totality of the time available, 1.7 hours. And so if you have 1.7 hours in a year, you would expect a large proportion of this will be to respond to the symptomatic and other complaints that the patient may have. And then there will be some fraction of time to do other things. So we have very little, a very small window of opportunity to intervene. So let's prioritize carefully. And what is next for grade in relation to shared decision making? I think that guideline developers need to think about how do you connect these patients like this arguments that you present in your recommendations with clinicians, this patient actions. And one thing that we're working with some professional organizations is, should we be developing the shared decision-making supports at the same time as the organization is developing and formulating grade recommendations? How helpful is to consider the evidence about patients' values and preferences, that the statistical distribution of these quantified, disconnected, decontextualized numbers that are obtained? How helpful is that? If at the end of the day your recommendation is sensitive to this, why do we have to use that distribution that represents no one, let alone the patient in front of you? Why not just lay out the factors that in a way that is helpful to engage patients in shared decision making? Again, the usual reason is there's not enough time and attention of clinicians to do it. Is that real? And where's the research about that? And the most interesting one is, should we delegate this complex work to AI? And I think there's a major concern in relation to AI, because to the extent that it is a black box where it's unclear what are the inputs and their validity and whose values are being introduced in those recommendations, when you, instead of considering a resource that's been developed rigorously using grade versus some other black box that tells you what to do, it's very, very difficult to turn to your patient and reason together, because you do not have the elements to actually reason together with the patient. You just have a recommendation of what to do. And that this impairs rather than facilitates shared decision making. At the end of the day, the whole thing that we're trying to do with shared decision making, particularly for patients with chronic conditions, is to make care fit in their lives. And this is a beautiful phrase from this manifesto that was published a few years ago. Patients and clinicians must collaborate in designing care plans that maximally respond to each patient's unique situation and priorities, while minimally disrupting their lives and loves. That is the beautiful work that we are all involved in. Thank you very much for your attention.
Thank you, Victor. We can take questions. People can put them in the chat and I can read them, or they can just turn their camera on and ask their question. I'm going to start with a question here. So the old paradigm in our earlier grade papers and that we teach is that shared decision making, when you have conditional recommendations, and when you have strong recommendations, you don't, or you're less likely to do it. Are you really are you really changing this paradigm? Like, is this just old news and shared decision making should be applied even to strong recommendations? You showed an example of that.
Yeah, I think the answer is yes. I think that the simplification, I mean, grade is a beautiful thing in terms of how it simplifies what is actually a very nuanced set of analysis and arguments to actually create a system that is reliable and democratizable. You know, people can actually engage in it. And some simplifications are really helpful and some not so much. And I think this is one of those that is not so much. You have to recognize that grade has another father, mother, I don't know what the parental thing is, which is decision analysis, right? Where you actually develop a tree and identify the options and identify the outcomes. And then to fold the tree in decision analysis, you need to have the utilities, the values that are actually quantified that make one arm better than the other. That is from a vision of rational decision making, which I think is already be clear that no human actually thinks that way or should think that way. And so, but that's still the baggage that grade carries with it, because it's early designers were trained on that model. And so I think the next generation has to think about differently about how do you make plans of care, and what is the role of guidelines at the individual patient level. Again, the one thing that is a struggle is this notion that our job is to push the evidence into the lives of people. But the thing is, it's the lives of people. Right. And so who are we to push these interventions just because a trial shows that A is better than B, or that 10 show that A is better than B? Who give us the authority to basically push this insight into the lives of people, regardless of who they are, regardless of what they pursue in their life. It's a level of evidence-based arrogance that needs to be checked, and I think grades should not contribute to that, but rather contribute the building blocks for patients and clinicians to make decisions together. And
So
whether that's a strong or weak recommendation, you would use shared decision making, I think, in a way that, I mean, many strong recommendations, I mean, there should be very few strong recommendations. That's the other thing, is that we're talking about the majority of great recommendations here, but there should be very few strong recommendations. And many of those are in the acute care setting where, patients may not be in a position to really, I mean, do I need to have a preference for you putting a couple aspirins under my tongue when I'm having an acute coronary syndrome? Probably not. You just put the darn aspirin in, right? I mean, it's not a big deal. But in most of the recommendations, when we're serious, we're going to actually make depend recommendation. We make conditional recommendations. And so for most of those, we have to take into account a bunch of different aspects of the situation, but not to apply the recommendation, but to respond to the patient's situation. And the recommendation is there to help us narrow down the kinds of options that perhaps we should consider. So we are not offering ivermectin to people with COVID, for instance.
right. So so on your last slide, you had something very provocative that you said, well, if these conditional recommendations, maybe we shouldn't make them. So what will be the alternative? Like, what do you have you thought of an example of something to present instead of a conditional recommendation that will follow?
Well, yeah, I think some of the tools that we've shown you, I think could stand instead, right? And so if you are dealing with this particular situation, and the way forward is to make a choice, a selection between alternatives, here's some information that is usually relevant in relation to the effects and the burdens and so forth, the practical the practical considerations you may want to consider, and let's discuss those and see if those help us arrive at something that moves the situation forward for you. Is that not superior to just say we suggest A over B?
Mhm.
And even in actually it's very tricky, because even in strong recommendations, you can have consistent randomized trial evidence that A is better than B, and that for some reason makes you you go all cardiology on it, and you go like, let's just make sure everybody takes it. If you actually look at it could be say a 20% risk reduction. I just show you with the statin example that a 20% risk reduction leaves most people indifferent as to whether they actually take the intervention or not. It's only a small fraction of people for which this makes all the difference in the world. And you just don't know who that would be. There's a radical uncertainty about it. So what makes us feel so confident that on average people will be better if only a small fraction actually makes a difference? On average, people should be indifferent in that situation. So I think it comes from the fact that we put such a high value in benevolence, right? That what can we do that will help? And we identify the things that can help, and we just feel then obligated to do them. But again, health may not be the only goal that people have in their lives, and taking pills to achieve health may not be the only way to live.
So really, the output of a guideline could be a few strong recommendations, if there are any, plus a few tools. Like, instead of a conditional recommendation, really the output is a tool.
Yeah, but you can imagine the nightmare of clinical practice if then you have to implement 3,000 tools for every consultation, right? So we also have to be mindful that perhaps we need a few rules of thumb, a few ways. I mean, recognizing that not many of these weak recommendations need a choice, a highly deliberate choice. Sometimes it is hey, it's sort of A or B. I mean, A is cheaper, it's
Mhm.
simpler, and why don't you just do? Maybe it's just an invitation, and the patient goes, "Yeah, sure, I'll do that." And so it doesn't. Not everything requires a
Mhm.
very deliberate, highly choreographed discussion. In fact, many of the decisions that we make are problem-solving ones, in which just knowing that there are these three things that you know potentially can have benefit, knowing that is helpful to put them on the table and have them as potential things we can offer to move the situation further. I think that we get in trouble when when we don't offer options because we have strong recommendation, or when we offer options for which there is no good evidence that they could potentially be beneficial, and in which case we're trafficking with people's trust.
Mhm. Yeah. So it's really illogical that any guideline would not have a tool, because it's likely that most of your recommendation or a lot of your recommendation will require some sort of a tool as
But they would
opposed to a
require some sort
direction.
of conversation. Let's just, I think
Yeah.
most recommendations are going to contribute to conversations. Some recommendations are going to contribute to decisions, and very few are going to contribute directly to action. Right.
Yeah.
And I think that's sort of the heuristic. And so that's a little different from the way we talk about grade these days. And I think there's an opportunity to creatively advance this standard in a way that begins to more closely align with what actually is trying to happen in clinical practice, particularly in the care of patients with chronic conditions, not so much in the acute setting with life or death decisions, where I think having strong recommendations for and against is actually very helpful.
Well, makes sense. Thank you.
I think you'll have a workshop coming up in which my colleague Iris Hargraves is going to speak about these issues as well. So let me put a plug for that workshop, because I think these issues will be further discussed then.
Right. And that workshop is focused on low certainty evidence. So situations where we're not very certain, and it would be ideal to have some support there for the decision or the conversation, not the decision.
Thank you.
Very good. I think that's it, right? Do you have anything, Madeline, on your end?
No, if there are no further questions, just thanks one more time to Victor for a wonderful presentation, and it was very much appreciated by our audience. A quick reminder, so you can register for future webinars at us.gradeworkinggroup.org. That keeps a calendar of all of our upcoming US Grade Network events. And then we will be hosting a network meta-analysis workshop in January 12th and 13th, to kick off the new year. And you can learn about that at www.systematicreview.org. So we hope to see you in future webinars or workshops. And thanks again for joining. Right. Have a great
Thanks, everybody. Lovely to see you all. Take care.